Well, hello there and good evening. It's 5 o'clock on your Tuesday evening, and you are right where you're supposed to be. It's Fertility with Fink. My name is Dr. Randy Fink, and I am a fertility gynecologist here at New Life Fertility in Pensacola, Florida. We also have offices in Tallahassee, in Panama City, in Mobile, Alabama, and in Dothan, Alabama. We see patients from all over this wonderful country of ours. And it is so nice to be here at 5 p.m. Central Time as we are every week, which means 6 o'clock on the East Coast, 4 in the mountains, and 3 on the West Coast. How is your Tuesday, everybody? So nice to see all my friends here. Looks like first to join is Zenny down in Miami. Thank you, Zenaida, for being here. Appreciate it. Hello to Anya. Sheila and Vic. Hi, Andre. Hello. It's great to see you as always. Teeny Tina. I like it. How you doing? Little Oak. Hello. Nice to see you. Emily Roth. M. Roth. Janae, Nady, GPTV, it's great to see you there. So we've got my Instagram account, that's Randy Fink MD right here. We've got Facebook, LinkedIn, and YouTube over here on this side. Now, ordinarily, we do this broadcast and include the Instagram page for New Life Fertility. So in its great wisdom, Instagram notified me that accounts that have less than 1,000 followers can no longer broadcast live. So it wouldn't allow New Life Fertility to put that live broadcast on tonight. So we're doing it here through mine, as always, Randy Fink MD. But I have a favor to ask of you. Would you mind? Would you go to New Life Fertility on Instagram and just be a friend of New Life Fertility? Friend that account. There were like 963. It didn't need very many more people to meet that 1,000 threshold. But if they could do that, that would be really a great help to this business here. And I'd sure be appreciative if you would do that. Hey, Sharmilla, how's motherhood? It's great to see you. So tomorrow you're going to see a picture of Sharmilla's baby, and I'm going to put that on. I'm going to post it in my story. You're a beautiful child. Such a long road you've been down, my friend, in order to get where you are now. And I hope motherhood is everything you could have hoped for and more. Hey to Wendy, J. Lou Scott, Angela, as always, thank you for being here. And Rosa, the same to you. Let's see here. So Little Oak says, I have my beta tomorrow. I just had my second FET. Can I also take a pregnancy test in the morning? So I think you're saying, can you do a urine pregnancy test in the morning and a beta HCG in the afternoon, or at least later on during the day? And the answer to that is yes, you certainly can. Now, it just depends on that urine pregnancy test. So the way these urine pregnancy tests work is that they are sensing a certain amount of the beta HCG in your urine. As you can imagine, these tests require a certain threshold value in order for that test to be positive. And if the amount that you have in your bladder at the time that you test is less than the threshold, the urine pregnancy test comes back negative. So it's not uncommon that we see false negatives with a urine pregnancy test. What you typically don't see are false positives, because if it's positive enough, if the level is high enough to trip the test, then it's positive. So that's how the urine pregnancy test works. The question is, can you do a urine pregnancy in the morning and the beta in the afternoon? In the blood, yes, absolutely you can. But you run the risk of being frustrated and scared and otherwise, confounded and confused as a result of a negative urine pregnancy test in the morning, whereas it may be positive in the afternoon. It just might not have met the threshold that would make that urine test positive. So there are a number of things that can diminish the presence of the HCG in your urine, depending on how much urine you actually have. If your bladder is really super full, that may dilute the HCG in the bladder out to the to the point where it doesn't trigger it. So I don't encourage the urine pregnancy tests. I know it's really hard not to do it because you just want to know that interminable wait between FET and pregnancy test. But that's the truth about urine pregnancy tests. So fingers crossed there, Little Oak. Boy, this is exciting times for you, right? So let's see here. And you are 10 days post retrieval, you said. So, by that time we ought to be able to, that's when we do a beta. But sometimes really at 10 days post retrieval, it may not be until 14 days post retrieval that you'll start to see it positive, 12 or 14 days in a urine pregnancy. So, Shada says, or Sharmila says, thank you so much. I'm enjoying it all. That motherhood thing. Thanks to you. Shada, hi. How are you? It's great to see you. How important, Rosa asks, is it to sleep on the left side in the third trimester? Does sleeping on the back increase the risk of stillbirth? It's a great question because we always tell you that in pregnancy, you're supposed to kind of be over on your side, sort of one way or the other if you can. And why is that? Well, as the uterus gets larger, it starts to sit on the big blood vessel that returns blood to your heart. And that's called the inferior vena cava, the vena cava. And when it's decreasing the blood flow that's going to the heart, then theoretically it can also be decreasing the blood flow that goes to the uterus because the heart is sending your blood out. That heart is pumping an awful lot of your blood. A very large component of your cardiac output goes to the placenta. So if you are lying on your back, you run the risk that you could be diminishing the blood flow going to the placenta. Now, here's the thing. You're going to go to sleep the way you go to sleep. And you could say, oh, I must go over on my side because that is the safest thing. And then once you're asleep, you're going to do whatever you're going to do when you get asleep. You're going to roll every which way. You may end up opposite direction in the bed. You may be half off the bed and on the floor. You may be all over the place. And there's just no telling because what you're going to do when you're asleep is really out of your control. So what can you do? How can you keep a little bit of tilt on you there so that it helps the blood flow going to the uterus so that you're not completely compressing the vena cava? And the answer is easy. Some people just prefer to sleep on their back. You can still really sleep on your back, but take your pillow, just put it a little bit under your shoulder blade or just a little bit under your hip. So instead of lying completely flat, that maybe you're just a little bit tilted. It doesn't mean that you have to be all the way over on your side. And that's the way I recommend that people do it. But look, to be honest with you, we're a pretty resilient species. And, how many people accidentally or incidentally sleep on their back at some point when they're in the third trimester of pregnancy? It happens. We are not so fragile that doing so, is going to result in a problem. But the thing is, if there is some issue, let's say with the blood flow that's going through the uterus to the placenta, and you may not know that, but then you accompany that by sleeping flat on your back and potentially decreasing the blood that's flowing by compressing the vena cava, that's when you may run into a problem. So just put a little bit of a tilt so that you're like this instead of, completely flat. That's usually the way I would advise my OB patients. JC says, best MD I ever worked for. Randy's the man. Oh, JC, you say all the right things. Nice to see you there, bud. What's the difference between an HCG wash and a Neupogen wash prior to an embryo transfer or frozen embryo transfer? So HCG, as you know, is the pregnancy hormone. And if you take a little of the HCG out of a vial, and then you wash the lining of your uterus with that HCG, then what it's doing is turning up the volume knob on some of the pregnancy receptors in that lining. That's what an HCG wash is. And When I worked in my former place of business, we recommended HCG washes for really just about everyone. To be honest with you, I think there is no harm to doing it. There is a little bit of cost to doing it, but it's fairly nominal. That's not an HCG wash is not a standard thing that most clinics do. It's not something that you will find kind of widespread, but there can be reasons for it. So certainly in folks who have had recurrent implantation failure or potentially even recurrent pregnancy loss, I think it makes good sense. Look, I'll be honest with you. There's really no harm to it. Now, Neupogen is a different story. Is there harm to Neupogen? Well, no, but I think the indication to use it is probably much narrower. Neupogen is a medication that is used for folks who have chemotherapy and whose blood count, white blood cell counts, are low. And what the Neupogen is designed to do is to boost their white blood cell count to prevent them from becoming what's known as neutropenic. That is to say, having a shortage of those white blood cells. So when we give you a dose of Neupogen, what it's doing is stimulating your body to make more white blood cells. And indeed, if we test those white blood cells with what's known as a CBC, or a white blood cell, your blood count, as it were, we may find that your blood count goes from a normal, which may be anywhere from 7 to 10,000, even a little lower, sometimes even 3,000, all the way up to 30 or 40,000 you may see with Neupogen. Now, that's when you take it systemically. When you place it inside the uterine lining, it's said to have some immune system mitigation effect. Now, exactly who that benefits is very hard to say. So, Shada, I think in your situation, would it benefit you? And I would say the answer is probably yes. Now, I know a little bit about your history, and we don't want to talk about that too much here in public, but I would say that certainly if you have a history that would support it, and that may be things like, pregnancy loss or implantation failures, or pregnancies that should have stuck but for whatever reason didn't, it may make sense. Now, it's also very useful in thickening the lining of the uterus in folks where hormones don't do such a good job thickening the lining. So it can really help to build a much thicker lining, and that's kind of where I think it's most useful. But certainly for the immune system, I would say yes is the answer there for sure. Hello to the wonderful Bama gal and husband, hopefully sitting close by. That's my beautiful parents in Mobile, Alabama, not too far from me here on the Gulf Coast. Thank you so much for being here on this Tuesday evening. They have a real hard time figuring out how to log into this thing. And every time I tell them, it's very easy. You just go to my Instagram, Randy Fink MD. And my mother says, okay, what was that name again? And I said, well, okay, if you don't know my name by now, we got problems here. But we're on Instagram over here. We're on Facebook and LinkedIn and YouTube on this side. If you didn't hear before, I can't broadcast tonight on New Life Fertility's YouTube just because they have less than 1,000 followers. And Instagram now says you can't do a live from a public account that has fewer than 1,000 followers. Would you do me the favor this evening, folks, of going to New Life Fertility, liking it, so that they're at about 963, I think is what it was. They just have a little bit to go to get over that threshold, and I would certainly be in your debt. Thank you for the consideration. Would you start stim if seeing a 16 millimeter follicle at baseline, that is to say cycle day 3? And so that's an interesting question too. So the next thing I'd want to know is, well, what are your hormone levels doing? So the follicle itself is not a deal breaker. If that follicle is secreting hormone and your estradiol level is generally greater than about 100, we would say, let's hold off. Let's see if we can't let that follicle go away. Let's see if we can't make it disappear. The concern I have about having such a follicle there is that, it's taking up valuable room. It's taking up real estate. really that the other follicles in the ovary are going to want to use in order to, have some space to grow. So that's my concern about it. But, we typically start IVF stimulations in the beginning of your cycle. The truth is, there's no reason that we couldn't start an IVF cycle at any time during your cycle. Yeah, that's right. Any time during the cycle, you could start an IVF stim. So, for example, if you are a cancer patient and you're just diagnosed with a cancer, and we need to do something like freezing your eggs in a hurry, or we need to get eggs from you so we can fertilize them because maybe you're going to start some kind of therapy like a chemotherapy that may be damaging, potentially damaging to your eggs. We can start that stimulation really at any point. So the follicle itself is not a deal breaker, but oftentimes we'll say, well, if it's above 14, maybe we want to give it some consideration. But certainly if it's above 14 and your estradiol level is above about 100, we really got to scratch our heads and say, well, hey, what's going on here? Are we really trying to start the cycle at the beginning of the cycle, or will that is it not going to matter in your case? Does that make sense? I hope it does. Nady says, how can I get a consult with you? Ooh, that's a good question. And I had an IUI last year, but it didn't work. So I'm at New Life Fertility in Pensacola, Florida, and that's the website for New Life Fertility is fertilityleaders.com, and all you have to do is fill out the new patient paperwork through the website, and the office will contact you, and we are happy to consult. We can do that by telemedicine. We can do it no matter where you are, or you're welcome to come in. So, Nady, I got to tell you, I do hear that sometimes when people say, well, you know what, I did an IUI last year and it didn't work, so something, really must be wrong. And I would say that's not the way I look at it, because an IUI with what's known as super ovulation or controlled ovarian hyperstimulation, ovulation induction, where the goal is to make sure that you're going to release at least one egg, but possibly even more than one, so that we can give sperm a better target. It doesn't have a super great pregnancy rate. It really kind of depends on your age as to what that pregnancy rate is. So in someone at about 30 years old, I would expect maybe about after about 3 cycles, maybe up to 25 to 30% possibility of pregnancy per cycle. You start to get diminishing returns after that. But when somebody says, I did an IUI and it didn't work, I say, that doesn't mean anything is wrong. It just means that the math didn't work out that time. The other thing I tell folks is that we are pretty inefficient in the way we reproduce. It only takes one sperm to get the job done there. One sperm is all it takes. But in order to reliably get that one sperm to where it has to be, it takes 20 million sperm for one sperm to get there. So it may very well just have been that the sperm didn't get there. Obviously we don't get pregnant every time we have sexual relations. So a lot of it has to do with the math. It's really about a math equation. And that's one of the things that we're here to help with. So Nady, I would love to see you and talk to you about that anytime. Angela asks, I have been taking DHEA 3 times a day, and my labs came back with a super high level at 868 and my testosterone at 169. Is that normal, or should I decrease the DHEA supplements? Well, so for folks who have a diminished ovarian reserve, the recommendation for DHEA is 25 milligrams 3 times a day. But you're right, 868 is probably a little higher than it needs to be. Now, I don't mind seeing a DHEAS, which is the test that we look at in your blood, that's at about 500. I don't mind that at all. Why do we use DHEA? And that's because it is a precursor to testosterone, and testosterone is metabolized into either the active form of testosterone, which is known as DHT or dihydrotestosterone, or into estrogen. So in the case of a diminished ovarian reserve, what's happening is that the testosterone that you're getting from that is increasing the estrogenic environment in which the eggs are growing inside your uterus, and thus potentially improving things that go along with diminished ovarian reserve. I do think that 868 is a little too high, and I do think that testosterone at 169 is obviously going to be higher than where you want for it to be. 500 is about where I would want to see it. So I would back down there, Angela. If you're doing 25 milligrams 3 times a day, I think if that's your number, you can probably stop it maybe for about 2 weeks and then resume it once a day, is probably what I would do based on that. Hello, the Familia Styles, Kimberay, Queen Lasito. My AMH went, this is back to Angela here, went from 0.7 last month to 1.58 from taking DHEA for only 3 days. I don't know what to make of that, to be honest with you, because the the AMH is coming from some cells that surround each of the eggs in your ovaries. So as we know, we're born with all the eggs we'll ever have, and we lose them over the course of our lives just to the process of aging. Well, each of those eggs is surrounded by these little cells. And so the more eggs you have, the more of those little cells you have. And the more of those little cells you have, the more AMH you make. AMH is anti-mullerian hormone. So we can't measure the number of eggs because there's probably millions or at least hundreds of thousands, and they're microscopic. So you can't tell, you can't see them individually on ultrasound. But what you can do is measure that hormone level in the blood. And we can chart that out and see where it is relative to other people your age, so we can tell approximately what we think of as your ovarian reserve. So is it normal that it would go from 0.7 to 1.58 just from juicing up the ovaries with a little bit of extra estrogen, pardon me, which is what happened by taking that DHEA? I would expect it probably would go up a little bit. I don't know that it would, more than double and call that, something other than a lab phenomenon. But I'd say, Angela, you did the right thing by taking the DHEA, and I'm very happy to see that number looks good there for you. So good deal. What does the AMH actually mean to us? Does it mean that you can't get pregnant if that AMH level is low? And I would say no, absolutely not. There are people with very low AMH levels who get pregnant, no problem at all. What it suggests to me, it gives us a number. And if you saw my Instagram post earlier in the week, or maybe it was last week, where I really encourage people to know their AMH, that's because it may give us a hint that ovarian reserve is starting to wane, or that the ovaries are aging at a rate that's faster than the rest of the body. And that may give us some clue that it's time to think about maybe freezing eggs, or that it's time to think about, well, we're thinking about having a baby next year. Well, maybe it's time to think about it this year. So I think it's definitely useful to know, but it is not the end all of fertility. What it does tell me is that it suggests how will your ovaries respond to medication. And that's very useful information for me to know, because I'm prescribing medication to try to get your ovaries to respond. So it's a useful metric, but certainly not the end all. My wife and I, this comes from Marquis, my wife and I can't wait for the IVF procedure, even though we are scared a bit. And I would say, well, of course you are scared, because it's not something that you do every day, right? It sounds very complicated. It sounds dangerous. There's a lot of medications. It sounds expensive. It sounds like there's, it's a mystery. It's involving things. It involves the ovaries, which you can't see. You have to have ultrasounds. It involves giving yourself shots. It involves eggs, which are a microscopic thing, and making embryos, which is something that, gosh, it's hard to even Imagine what that means, because it's something that's done in the laboratory. In that scenario, um, um, of course it's scary. We don't, it's not something that you do every day, but fortunately we do. This is something that we do every day. And so we're very, very comfortable with it. And Marquis, I would hope that you would uh, want you to, I hope that you would have the confidence in the people who are taking care of you, because that's really what it comes down to. And I feel very strongly about this, that if you can't have confidence in the people who are guiding your care, then you should go someplace else, because there are so many fish in the sea that can help you with fertility. There are a lot of fertility specialists out there. So I think it's really important that you have a good relationship and you trust what they're saying. When you make a phone call, can you get an answer in a timely fashion? And you know what? Let's address that, because no, it may not be a situation where you can call and get an answer immediately. Doctors' offices just aren't like that anymore. But what about, do they call you back that day? Do you get the answers that you need? Do you feel comfortable knowing what your next steps are? Those are the kinds of important questions to ask yourself. Because if you're not getting the level of comfort that you want to make yourself comfortable, because that's another way to kind of have a little more control over the process. Taking the Clomid you prescribed, and she's taking all the vitamins as well. Outstanding. So we're working on egg quality there. So one day at a time, my friend, we're getting closer and closer, and happiness is just around the corner. If you're just joining, it's almost half past the hour. This is Fertility with Fink on Instagram, Facebook, LinkedIn, YouTube. Glad to have you here like we are every Tuesday evening at 5 o'clock Central. Hey to Beach Bum and Noodles for Life. Nice to see you. Beach Bum says, what should my estrogen level be for a modified natural midway labs after a day 3 transfer? Well, I'll tell you. We don't really need to know the estrogen level. So then why do you check it? Well, there's some data that says that the ideal number is somewhere between about a 200 and a 500. But that doesn't mean that if it's lower than 200 or if it's greater than 500, then there's something wrong. Because you absolutely can get pregnant with that. The most important thing to know about your estradiol level is simply, was it sufficient to give you the thickened trilaminar endometrium at the time of your ovulation? So right at about mid-cycle. That's really what you got to know. So once you then start your progesterone, or in your case with the natural cycle, once you've ovulated, that lining is going to start to become thinner. And that's, really to be expected. It goes from being what's called trilaminar, or having what appears to be 3 layers, to then being really kind of heterogeneous, meaning to say kind of mixed in its appearance. And that tells me that the progesterone is doing its job. So what's the number you're looking for? Well, I'd be more concerned if the number is very low, then maybe we want to supplement you on a little bit of some estrogen. But other than that, the number really probably doesn't matter so much. Does removing the tubes, Shada asks, help with the outcome in carrying to term? If so, should one consider removing them even if the tubes are open and healthy? The answer is no. Removing the tubes can decrease the risk for an ectopic pregnancy, but if you're doing IVF, the risk for an ectopic is already really very, very low. The only situation where removing the tubes is something that's needed is in the case where one of those tubes is blocked and is full of fluid. And that's called a hydrosalpinx. So if you have a hydrosalpinx, we know that placing an embryo back inside is dangerous, because the fluid that's in the tube can wash its way back down into the uterine cavity and is toxic to an embryo. So in that situation, at least blocking the tube is recommended, but taking it out would really probably be the better choice, because sometimes if you just put a little blockage on it, it can start to throb and cause some pain later on. But I would not recommend that you preemptively remove fallopian tubes if those tubes are open and functioning. It should not have an impact on your ability to implant a pregnancy or to carry it. Bryn says, my placenta was low at 16 weeks and 2 days. Is this normal and will it rise? Yes, in all probability, it will. So the location of the placenta is said to either be what we'll call normal. It can be something that is called a placenta previa, where the placenta is actually over the opening of the cervix, or it's said to be low lying. And what does that mean? Well, let's say that here's your uterus. Okay, so here's the cervix, which actually, might be pointed down, but we're going to point it up just so you can see. Here's the uterus. The placenta sits, kind of on the inside, on top of along the uterine wall. All your blood flows through that placenta, and to the baby. Well, as the uterus grows and gets bigger, the placenta typically moves along with it. So to answer your question, yes, in all probability, that placenta will move. The placenta, if it's implanted right here over the opening of the cervix, well, that's called a placenta previa. And that's something that can be potentially dangerous. You can't have a vaginal delivery with a placenta previa, and those things can bleed and can start to really cause you problems. So a placenta previa is also something that we follow, but in some cases, it may just resolve on its own. So a previa is right here. A regular placenta is here. So a low-lying placenta is something that just sits kind of close to that cervix there. And my expectation is that as the uterus grows, that placenta is going to probably move along with it. So not an uncommon finding, especially at 16 weeks of pregnancy. So congratulations on your pregnancy there, by the way. That's very happy news. Noodles for Life says, sorry, I missed the beginning, but is an HCG wash the day before a medicated FET helpful or not? And is it worth it if only done within a 24-hour window? So we talked about HCG washes, where we place a little bit of the pregnancy hormone inside the uterine cavity. And the answer is, it certainly isn't harmful. It may not be helpful to everyone, but it's very hard to identify who the specific group is for whom it's helpful. If it's done with less than, it's typically done 24 to 48 hours before. If it's done a little sooner than that, it's probably okay. I don't recommend that an HCG wash be done on the day of transfer. There are some people who say, oh, that's the way they like to do it. They do a mini HCG wash so that they don't have a lot of extra fluid on the inside, and that would be my concern. I don't recommend that you do that. I think it's better to do it 24 to 48 hours before. But if you do it, a little less than that, is it a problem? Not if it's a low dose. Is it worth doing? I think it is always worth talking about. Marquis says, is a typical IVF procedure priced, and are there options for financing? So it depends on where you go. Here at New Life Fertility, yes, absolutely. There are several different options for financing. Our charge here for IVF is on average about 40 to 50% less than charges in other cities. So for example, if you live here on the Gulf Coast, the cost of an IVF cycle in, let's say, Mobile, Alabama, is about $18,000 for the IVF itself, plus your medications, plus, the other stuff that you end up doing. Whereas here, it's about $12,000. There is a discount we offer for the military. If you were to go to a city like Atlanta or, kind of a bigger city, IVF can cost, sometimes $30,000 a cycle. Where I used to live, there were some practices there in Colorado that charged really $25,000 to $30,000 just for the cycle alone. And to be honest with you, I don't see that there's a reason that it needs to cost that much. I really feel like it doesn't have to cost that much. But it's, yes, financing options are always available to folks. Hi, Lana Toasts and Midgie. Nice to see you. It's been a little bit. Ariel Eden, hello there. Can you do a Neupogen wash? Angela asks. The same day of your retrieval for a day 3 fresh embryo transfer. So 3 days before. Yes, you could. Yeah, sure you could. At the time of a retrieval, absolutely you could. If you felt like a Neupogen wash was going to be something that was helpful. Shada says, I am in my stim cycle, stim day 7. My estradiol came back at 16. It was 11 at baseline, just a couple of tiny follicles. What's the reason for the estradiol not rising? Would you increase the follistim and the menopur? Well, the first thing I'd have to ask you there is, were you on letrozole as well? That practice tends to use a lot of letrozole as an adjunct in people, and letrozole will falsely lower the estradiol level. So it really becomes not a useful marker in trying to understand what estrogen is doing. Now, if you were not on letrozole and your estradiol is only at 16, I would say, well, you're probably not really recruiting many follicles, because it's those follicles that are going to make your estradiol. So yes, in that situation, I definitely would think about increasing your stim meds. Ariel says, I had a laparoscopy in April. They said my tubes were blocked. Can I do an HSG to try to unblock them? Well, there are some procedures that you can do to attempt to unblock tubes, and that's called selective tubal canalization. And what you do with that is that it's usually done by, at least nearby the HSG machine, and oftentimes with a hysteroscope, which is a camera that looks inside. And what they do is you take a special type of catheter and place it right up to the tubal opening and try to forcefully blow some fluid into the tube there in an effort to try to unblock it. Now, the problem with that is that it may already suggest that you've got damage to that tube. So if there's already damage to that fallopian tube and you unblock it, then you run the risk of significantly increasing your odds of an ectopic pregnancy. And that's something certainly we would like to try to avoid. Ectopic pregnancies, or a tubal pregnancy, is something that potentially can be life-threatening. So doing something to try to unblock tubes is not always effective and may just kind of increase some risks for you. There was also a question Shada asked from before about, or should I just, cancel the cycle? Well, there's another interesting and potentially useful measurement that we might use in the beginning of an IVF cycle, and that's what's known as an antral follicle count. Well, what does that mean? We talked about the eggs in the ovaries. Well, we can't measure the number of eggs because they're microscopic. But in the beginning of a menstrual cycle, your brain starts screaming at your ovaries, and it tells the ovaries, hey, I want you to dig around and get me some eggs, because these eggs are all going to fight with one another, because one of them is going to emerge as what we know as the dominant egg, or the dominant follicle, and that's the one that you're going to ovulate when the time comes. So the number of eggs that it generates, or that it kind of digs up from the ovaries at that big point in the cycle, those are called antral follicles. And so it's a little egg in a tiny little egg house, which is a little space that has a little fluid around it. So we can count those number of eggs. Now, even though that number can vary cycle to cycle, I would say that to answer your question, should you stop the cycle? I think it depends on what your antral follicle count might have been. Because if there were a reasonable number of follicles that were hanging out there, like let's say that you had, 8 follicles on one side and 8 on the other for an antral follicle count of 16, and your estradiol's not going up, it's not doing much, then I might say, okay, well, another good indicator to probably increase your stim medication. So lots of different ways, lots of different things that we look at there to see, how to individualize a cycle. And that's the other thing that I think is important. I do recommend individualized cycles where changes can be made after every visit, that it's really monitored by a provider after every visit, so that you know that what you're doing is the right thing and that nothing is missed. Let's see what else. Beach Bum says, what should, I think we answered that one. Hello, Blaxican Beauty. Oh gosh, Nady says, I'll be in Orange Beach, Alabama in 2 weeks. Can I try to get an appointment during that week? I live in Kansas City. The answer is yes, absolutely. We'd be happy to see you when you're in Orange Beach. Just make sure you fill out that paperwork. And if you don't get a quick answer there, then by all means, just instant message me through Instagram here. And I'll make sure that we can see you. Orange Beach, Alabama is a wonderful and beautiful, beautiful place to be. This part of the Gulf Coast, I have to tell you, is some of really the most beautiful ocean front, some of the most beautiful sand. I think, I've been to beaches all over the world. I love the water, let's say, in the Bahamas. And they say that from space, the Bahamas are really probably the most beautiful water in the world. But as far as beach and that white sand beach, just beautiful, miles and miles of pristine beach and pretty water, you just don't do better than the Gulf Coast here. So welcome you in advance here to the Gulf. It's a storming here tonight, though. I tell you, I don't know if you can hear in the background, the rain is falling, the thunder is crashing. And so if you hear a little bit of noise, it's not just that I'm gassy. Okay. Hey, Dr. Pena. Dr. Pena in Miami says, you are the best doctor, very compassionate and caring. Dr. Carlos Pena in Miami, a wonderful GYN surgeon and obstetrician as well. If you are in Miami, go see Dr. Pena because he is a class act, I'll tell you. Let's see. We have, I got benefit from, Shade is sharing. I got benefit from acupuncture and taking all the supplements from Dr. Fink's Vitamin Victory book. So yes, I did write a book on that. It is called The Vitamin Victory, and that's about what can a handful of vitamins do to help us get pregnant. And if you are a patient here, I'd share that with you. Otherwise, the ebook is $7 easy, and you can see that on my page on my Instagram, on the link in my Instagram. So please check that out. And again, Dr. Pena, thank you for your kind words. I got my thyroid hormones back to normal, says Blaxican Beauty. My antibodies are still a little high. Should I wait till next cycle for my antibodies to normalize, or am I good to go? So, that's a great question. The antithyroid antibodies, or the thyroglobulin antibodies, are something associated with an autoimmune type of thyroiditis. That's an inflammation of the thyroid that comes from your immune system. Now, in her case, she ended up being very hyperthyroid because of this, and was put on some different medications that really probably were not optimal for doing an embryo transfer. We like to try to see those antithyroid antibodies brought back closer, if you can, to the normal range. And how do we usually do that? We do that with prednisone. Prednisone is a steroid really taken in the month before doing an embryo transfer, has been shown to have favorable outcomes in folks who have markedly elevated antithyroid antibodies. And so that would be the thing that I would certainly want you to consider. Which would you think would be better in helping thickening the lining, a Neupogen wash or a PRP wash? Well, I'll tell you, a PRP wash is to me a little bit more reliable. PRP is platelet-rich plasma, and that is where we take a tube of your blood and we separate out the component that is what we call your tissue factors, your healing factors, your growth factors. And we're able to place that tissue back inside of you in the form of a liquid. We can wash that uterine lining. And it is, kind of what I would consider to be one of really probably the best salve that we can make for just about anything. And I think that holds true also for the uterine lining. So I would say, given that choice there, I would go with PRP because it's pretty reliable. Certainly, if PRP didn't work, then Neupogen is a good choice. Now, some of that may also kind of have to do with timing there, Angela, because usually if you know that you're going to have a hard time growing your lining, then you might do that PRP wash at the beginning of your cycle rather than just a few days before transfer. If, however, you've done it and then a few days before transfer, the lining is pretty thin, Neupogen might be a quicker answer. And I would also add some baby aspirin to that because that increases the blood flow to the uterine, to the endometrium there as well. Hello, Daisy. It's nice to see you here this evening. And Dr. Pena is sending lots of love our way. Thank you, Dr. Pena. In Miami, Dr. Carlos Pena, an OBGYN, extraordinary gentleman there. Thank you. Present says, what are the other reasons for a chemical pregnancy except for chromosomal issues? Well, so a chemical pregnancy, and let's just make sure that we're talking about the same thing. A chemical pregnancy happens when the hormone levels start to go up and then they reverse, they start to go down. And that happens before you're able to do an ultrasound to see the location of the pregnancy inside the uterus. So once you've looked with the ultrasound and you've seen the pregnancy, that is what's known as a clinical intrauterine pregnancy, whereas a biochemical or a chemical pregnancy happens when the level goes up, but it's before you've been able to see anything on the inside. Chromosome reasons or unhealthy embryos are considered to be the most common reason, unfortunately, that a biochemical pregnancy will occur. What can be some other reasons? Well, certainly if there's an issue with the lining, certainly if there is some concern about is that lining getting thick enough, or potentially is there something autoimmune that's standing in the way on the mom's side? Is there some scar tissue in the uterus? Is there a polyp or a growth on the inside that may be inhibiting the implantation? These are all possibilities, but in most cases, when those pregnancies start to implant and then they stop growing, it's usually considered to be an embryo factor. And that's a frustrating answer because you can't always look into an embryo and see it. And you can't know how healthy your embryo actually is, even if you've had it tested. It's not always, oh gosh, a little thunder there if you heard that. You can't always tell from looking at the embryo or even with a tested embryo. So that's the concern, but most commonly an embryo issue. Does DHEA cause a lot of cervical mucus? That's what I've noticed when taking it. Well, remember DHEA becomes testosterone and ultimately becomes estrogen. So as you increase your estrogen levels, that can definitely increase the kind of vaginal discharge you have. That lining typically becomes more watery and kind of, sticky that you could keep it between your your fingers. There's a term for that. It's called Spinbarkite. It happens as a result of the progesterone, but certainly more estrogen, can yield to more fluid coming from the vagina for sure. Kimberay 12 says, the fresh transfer you did for me last summer in Colorado worked. Oh, hey, that is awesome to hear. My baby boy is now 4 months old. Thank you for giving me such a positive experience. I can't thank you enough for coming on here tonight and sharing that with me. Would you mind sending a picture? Because I would love to post that picture of your baby. Boy, that is just great news. Love to hear that. What is your guidance on Emma, Alice, and ERA testing? So, I would say the answer to that is I wouldn't do it. So the ERA is something that's known as the endometrial receptivity assay. And we used to think that there was a very specific time that your embryo would implant and that it was normal and to be expected in 75% of us, but that in 25% of us, it was different. And if things weren't working, then we would ultimately do this ERA, this endometrial receptivity assay. Well, it sounds like a really good idea, and it does, doesn't it? It sounds like, oh yeah, man, that makes all the sense in the world. And it did for a very long time until they kind of did a deep dive on that. And what we ultimately found was that the ERA did not make a difference in pregnancy outcomes. It's an expensive test. It's an uncomfortable test. You have to do it during a mock cycle. And at the end of the day, no matter what the result was, it really didn't change the number of live births. And so it has really fallen out of favor as a test. It used to be, even maybe 2 years ago, if we had this conversation, I probably would have been recommending an ERA for you because that's what we had in our armamentarium. Now we know that, it's probably an expense that is not justified because it doesn't change your outcome. The test that went along with the ERA was something that was called an Emma and an Alice. The ERA, the Emma, and the Alice are what they call the endometrio. Catchy, right? They marketed this very heavily to the consumer, not as much so to the doctors, because they wanted consumers or patients going in and asking for the test. There really is not good evidence that altering or looking at the microbiome has any lasting impact on implantation or on pregnancy. Now, certainly if you've got some chronic type of discharge, some people have chronic yeast infections or chronic bacterial vaginosis. I think in gynecology, there probably is a use for it. Could there be an indication for it in the fertility world or in obstetrics? Maybe, but in the studies that they've done that have looked at it, it really hasn't shown that it makes a difference. Again, it's one of these things that just sounds like a good idea, but what they're doing is, especially for folks who are seeking hope for situations that feel desperate. And when you've done some transfers and they don't stick, or you've done transfers and they do stick, but they stop growing, or something happens to your pregnancy, you're looking for answers. You want an answer. We're so used to being in control that you want something that feels like it's giving you more control. So to get some diagnosis that says, oh, your lactobacilli is slightly out of whack, so therefore you should take these probiotics and that's going to fix things. Well, you can take the probiotics, but they're just not shown to make a difference. And what we're doing really in that scenario is getting people to pay money, good money, and those are expensive tests, good money for hope. And in my mind, hope is a very important part of what we do because we need that hope, but hope is not a strategy for getting pregnant. If hope was a strategy, you'd be staying home just having repetitive intercourse and wondering why month after month you still get a period. And that's a very frustrating thing. But you have to kind of measure out, well, which is more frustrating? Something that sounds like a good idea that's kind of trying to get you to part with your money in favor of getting some hope and some control versus going where the evidence takes you. And that's really where I would encourage you to stick. But it's a tough situation to be in for sure. And that's why, I always say, every day forward with hope. And you'll hear me say that in a few minutes when we close the show here. Every day forward with hope, because tomorrow is a new day full of all new adventures. So we have to have hope for tomorrow, but I don't want that to be your only strategy. And I don't want you to throw money at hope when science may tell us other things. Let's see. Angela says, my lining is always thin, around 6 to 7 millimeters, and I want to do a fresh day 3. Could I do both Nubigen and a PRP wash at the same time? Yeah, you sure could, especially if you were doing that at the time of your egg retrieval, because it's kind of a lot of volume. You would be asleep for that, really, so you wouldn't feel it. Now, 7 millimeters is the number that we look for when it comes to how thick does your lining need to be. So 6 is a little thinner than I'd like it to be, but it would also make me wonder, well, what about the blood flow to the endometrium? If I looked at the blood flow, would I say, well, you're consistently 6 millimeters, but it's got really excellent, strong blood flow there? Would that change things? I'd be curious to see that, Angela, and it definitely could. Well, let's see what else we got going on here tonight. If you didn't hear me mention before, I would be very much in debt to you if you would go to New Life Fertility's Instagram page and friend that account. So normally this broadcast would be on my Instagram, which is Randy Fink MD, on New Life Fertility, as well as New Life's Facebook, LinkedIn, and a YouTube page. But Instagram has said that accounts with less than 1,000 followers cannot do live presentations. That account for New Life Fertility was 963. So if we could just get a few more people to please go to it and follow it, I would be forever in your debt. And then all the people who would like to watch that on New Life Fertility's Instagram can do it as well. I hope you'll follow my page here, Randy Fink MD, if you don't already, because try to put out some content that is both helpful and meaningful to you in your journey and your quest as we all travel down this highway. It is indeed a journey, isn't it? And all journeys are not pleasant ones. They are difficult, especially this fertility business. And that's why I am very fond of saying that this fertility business is not the book of your life. It is just a chapter. And what are we here to do? We are here to rewrite it together. So every step forward with kindness to the others around us, because you know what? The world is not a kind enough place, and anything that we can do to foster that, even just a little bit, smile at a stranger, wink at a child, wave at a little child, stop and pet a dog, do something nice, do it for yourself, do it for other people, and the world suddenly becomes a little bit better because of the work that you've done. And most of all, every step forward with love and with hope, because tomorrow is a new day and it's full of all new adventures. And let's grab them, shall we? Until next week, I'm Dr. Randy Fink from Pensacola, Florida. Thanks so much for being here, and good night. See ya.